My name is Abizaid. I practice interventional cardiology in São Paulo, Brazil. And it's my very great pleasure to be the chairman of one more in-cath lab webinar entitled Uncaged Bifurcations. This is again a very provocative title that we have great experts to present cases and to present data with a very fruitful discussion after each case. So to be with me today, I have Dr. Simon Eccleshall. I also have from UK. I also have Sophie Degrauwe from Geneva, Switzerland, and my friend Carlo Briguori from Naples, Italy. So it's my very pleasure again to introduce first Simon to give the first lecture, lesion preparation in DCB angioplasty. Again, this is an opportunity we have to talk about DCB in different indications, but particularly for bifurcation, side branch together with DS. This is a very exciting theme that I want to explore with you today. Simon, the floor is yours.
Great, thank you very much. Thank you for the invitation. Hopefully everybody can see my slides. My name's Simon Eccleshall. I work in the UK and I have an interest in DCB-only angioplasty. So what I was going to talk to you about today is lesion preparation, show you a few of the things that we've learnt over the years and focus a little bit on bifurcation strategies as well. So lesion preparation is really about good vessel expansion with less than 30% recoil whilst preventing vessel-threatening dissections such that you can achieve an optimal DCB result. So really it's about relearning balloon angioplasty and it's all about recognising dissections. So lesion preparation for DCB-only angioplasty, we aim for 1:1 balloon-to-artery ratio with no vessel-threatening dissection, as little recoil as we can get. We use a lot of nitrates or vasodilators before and after lesion preparation to reveal the maximum vessel size and ensure that we have 1:1 balloon-to-artery treatment before we consider a DCB. Any concerns you might have about how long the DCB needs to be inflated, and they vary from manufacturer to manufacturer, but between perhaps 30 and 60 seconds, you can address those concerns at this point in time with a slightly longer inflation with one of your lesion preparation balloons. So here's an example of 1:1 balloon-to-artery ratio. You can see a very tight lesion in the LAD. This was so tight we had to cross it with a small balloon. The other important thing to remember with lesion preparation is to pick the right size, not only diameter, but length of balloon. And then your DCB has to be a little bit longer. And certainly that's something that we've been picking up in the de novo study, is ensuring that people are covering at least everything that's been touched with a lesion preparation balloon and a little bit more. So again, there's a very tight LAD lesion, a lesion preparation balloon, the DCB, and that result is almost stent-like, but without a stent, I would say. So the potential problems with lesion preparation come down to undilatable lesions, like in any angioplasty, recoil, or the vessel-threatening dissection. So I'm going to talk a little bit about those. So with the undilatable lesion, what you want to try and avoid is very high pressures, particularly with the first balloon, if perhaps you've taken a semi-compliant balloon, because what you want to try and avoid is that dog bone effect where you've got a very tight, undilated bit of balloon and then two bits of the balloon that are getting ever bigger, because you're running the risk of getting a uncontrolled dissection, but in the setting of still a lesion that's not fully dilated. So one of the ways to work around that is to gradually increase pressures only as required, and sometimes even just going to the same pressure with the same balloon on a number of occasions, i.e. repeated inflations, can help. Certainly nowadays, we don't use semi-compliant balloons much at all, except possibly to cross very difficult lesions. So I tend to start with a non-compliant balloon, usually of the right size, to the balloon-to-artery ratio. If that isn't going up, a little bit more pressure, a little bit more time, and then you consider changing to cutting or scoring balloons as guided by the amount of calcium, the anatomy, and your experience. You can change between specialty balloons, such as cutting to scoring and high-pressure balloons, and certainly rotablation and shockwave have been used successfully with DCB work and rotablation series have been reported with DCBs. So here's an example of an undilatable lesion. As you can see, the non-compliant balloon on the top left with very much a waist in the middle. So we went with a score flex, so a non-compliant scoring balloon. Again, that wasn't going at the same point. After repeated inflations at slightly higher pressure, you can see now that the balloon is fully inflated, and the bottom right picture shows a nice angiographic result. So for recoil, for all the consensus documents that there are out there and for studies related to DCB work, everybody's aiming for less than 30% recoil at the end of lesion preparation before you deliver your DCB. So if you're getting recoil, one of the first things to do is to try gently a little bit higher pressure for a bit longer with the 1-to-1 balloon to artery ratio balloon that you've been using. We find that if you're still getting a lot of recoil, then changing over to any scoring or cutting balloon usually makes the difference, unless, of course, actually what's happening is you've got an undilatable lesion rather than recoil, in which case you have to consider shockwave, high-pressure balloons, etc., as I mentioned earlier. These are some of the balloons that we have or have had on the shelf, and we certainly use an awful lot of the different cutting and scoring balloons on a daily basis. So this is an example of recoil. Top left is 1-to-1 balloon to artery ratio, the initial balloon. There's the recoil in the mid-right coronary artery. We then used a score flex scoring balloon, and then top right, the angiogram shows a much better result. So dissections, which is probably the trickiest part of all of DCB angioplasty, really. All the data around which dissections are safe to leave is very old data, essentially pre-stents and therefore pre-dual antiplatelet therapy, and actually at a time when angiography was much more difficult than it is now. There wasn't really much in the way of intravascular imaging. But essentially, what we learned way back then was that type A and type B dissections were safe to leave. Some of the others most distinctly aren't. Type C, there's a little bit of a debate around it. So this is an example of, again, a left anterior descending artery lesion. You can see that's very tight. We've got a lot of recoil in the top left picture after non-compliant balloon. So we went to a scoring balloon, and you can see top right now that that looks even worse after the scoring balloon than before. And in the next few minutes, while we were giving the patient more nitrates and deciding what to do, it became rapidly apparent that he had an occlusive dissection. As you can see, bottom right, there's luminal compromise, which must be an intramural hematoma compressing the vessel, and there's only TIMI-1 flow distally. So obviously this requires stenting. Here's some examples of dissections that are safe to leave. On the left picture, that's a type A dissection, so it's a small tear visible within the vessel. That's at 2 months follow-up. In the middle, you can still see the healing dissection, and by 6 months, the vessel looks normal. Here's a type B dissection acutely, and again, here it is at follow-up. I just realised my arrows are in the wrong place. It's down here, look. And again, at 6 months, it's healed very nicely. Here's a type B dissection in the mid-right coronary artery, and you can see the double lumen here. As long as this contrast clears quite quickly and you have TIMI-3 flow, again, this is a safe lesion to leave. So dissections, essentially type A and type B are safe to leave. Further balloon angioplasty can resolve the ambiguity around some of the dissections and can turn those that you're wondering whether they're safe or not into safe dissections, or those that clearly need stenting. Anything above a type C dissection does need stenting, but we've termed it dissection modification, whereby you work harder with cutting or scoring balloons. If there's persistence of contrast after a few cardiac cycles, this is usually a red flag to tell you that there's a problem and you need to look at that lesion in more detail. So very quickly moving on to bifurcations. Generally, we treat them in the same way as a single lesion, with preparation to the main branch and side branch only if it needs it. Particular care, particularly at the aorto-osteal junction and osteal bifurcational lesions with a much lower threshold for cutting or scoring balloons. I think because of the fibrotic nature of the vessel at that point, they are more resistant to normal balloon angioplasty. A little bit like the European Bifurcation Club guidelines, we would suggest we're only to pursue the side branch if it's a significant size vessel with more than 5 millimeters in length, and or if it becomes compromised during the procedure. We tend to treat them sequentially with balloons and then sequentially with drug-coated balloons. So the need for kissing balloons is very rare in any DCB approach, as long as it's DCB only, not DCB in stent. Depending on what type of balloon you're using, you may get late lumen gain within the main vessel that then gives you side branch ostium gain as well. So here's an example of an LAD D1 bifurcation. Both of these branches were pressure wire positive. There's the sequential ballooning. There's the sequential DCBs. Again, you can see that we're using a balloon that's slightly longer in the main branch. It probably isn't here, but actually you need to remember that back in the main branch, we've already covered that with a bigger DCB, and that's the acute result. So the next part of the DCB and the angioplasty after lesion preparation is what we like to call the checklist in our cath lab. So it's very standard stuff. Is the patient pain-free? Do they have a normal ECG? Do they have TIMI-3 flow? Is the vessel big enough? Have you treated it enough of the diameter and enough length in diffusely diseased vessels? Will the DCB be deliverable? We have quite a low threshold for using any sort of guide extension. Do you have a good enough lumen gain? Again, you want less than 30% recall, and you want to know that all the balloons have been fully inflated. One of the questions I sometimes ask myself is, does this lesion now look like one that would cause ischemia or be pressure wire positive? And if you're thinking that it would not be the cause of ischemia, you've probably done enough work with your lesion preparation. What dissection grade can you see? A's and B's are fine. Is the contrast persisting? If there is, you need to look at it very carefully. TIMI-3 flow obviously is required, and then the DCB must be at least the same diameter as the vessel and presumably the last lesion preparation balloon you've used, and it must be a little bit longer at either end. If you can't decide, you can wait, you can give the patient more nitrates, take a different view, or ask somebody else to come and have a look. From the point of view of DCB delivery, then it breaks down into, as the DCB is going in, you want to check, first of all, that everything is in the right place. So your guide is well seated, your wire is in the right place. You try not to touch the balloon when you're putting it into the system in case you dislodge any of the drug. You want to take a note of the time that the DCB enters the system, because depending on which one it is, there might be a time limit. And again, you want to know how long you've inflated the balloon for from the point of view of the instructions for use. You need to cover more than 2 millimeters either side, and it should be a very slow, gentle inflation. You only need to touch the sides to deliver the drug. It's certainly not about doing any more angioplasty, it's just drug delivery. Afterwards, it's the same DCB checklist, which boils down into how's the patient, is there any recall, have you created a new dissection, and is there contrast persistence, which would suggest perhaps you've done something new that's a problem. So that's a very quick run through how we perform drug-coated balloon angioplasty. I'm very happy to take any questions, or we could go straight into the cases.
Thank you so much, Simon. I think this was a fantastic talk. I know that the time is limited. There is so much to discuss. And I'm sure that during the cases, we'll be able to talk more about technique. But I have one or two burning questions to you. And then, of course, if Sophie and Carlo has a question, please go ahead. But my question to you is just to make sure that I understood your advice on how to perform DCB in a side branch bifurcation. Do you generally perform a kissing balloon with POBA, with plain old balloon, and then you go with a DCB on the side branch because you want to cover the ost of the side branch when you do provisional, but you perform another kissing with a DCB at the osteo together with POBA in the main osteo? Tell us, just to make sure that we understood, what's your advice to perform a DCB on the side branch of bifurcation?
Okay, so as you probably noticed from the way I talk, we try very hard not to stent anything at all. So all of my talk was about DCB only to either the main branch or the side branch or both. So if I was doing just a side branch lesion, I would wire the main branch, probably cut or score the side branch to the right lesion only, and then only DCB the side branch. If I was doing the main branch and the side branch, I would just treat them both separately. I would balloon the side branch to the right size. I would balloon the main branch to the right size, again with a low threshold for cutting or scoring balloons. And then I would use a DCB the right size for the main branch and a DCB the right size for the side branch. And this is all individual balloons, one after another. If you do that, you find most of the time, because you're sizing correctly, you don't get carina shift. And the frequency with which we use any kissing balloon, if we're not using stents, is very, very low. The only time I would consider kissing would be if at the start of your lesion preparation, you notice that by ballooning one branch, you're losing the other one, and you have to balloon that open and then the other one goes. My approach then would be to do a very gentle kiss to both of them to see that I can get a fairly good balloon result in both branches at the same time. If I can, I would then just DCB one and then the other, and then if necessary, re-kiss at the end to put it back to anatomically normal. But it's really rare now that we kiss if we don't put stents in.
Good. And then my final question is, before we go ahead with the cases, is that I saw in a couple of cases that you presented, great examples, by the way, was that if you wait 10 minutes, 15 minutes, you generally see some recoil that might change your strategy, either to cross over to stenting or to perform another balloon inflation. I remember on my early days of angioplasty, when there wasn't, that stents did not exist, we used to do that as a routine, to wait 10 minutes before you finish the case. Is this what you try to send a message, or is in a couple of cases do you do that? When do you do that?
We hardly ever wait 10 minutes nowadays. Most of the time, if you've got a great angiographic result, we literally check the patient's spine, take a picture or two, depending on the complexity of the lesion. And if there is no dissection or no vessel-threatening dissection, the whole checklist is fine. We hardly wait at all. If there's any doubt, any ambiguity, then obviously we wait longer, take repeat pictures, give the patient more nitrates, maybe take a different view. But the majority of the time now, no, we certainly don't wait 5 or 10 minutes.
So I think we should move ahead. Simon, you stay with us because you're going to help me with the discussion during the cases.
Sure.
Again, my pleasure to introduce Sophie Degrauwe. She works at Geneva University Hospital in Switzerland. Sophie, please share your case.
Thank you, Dr. Abizaid. So I'm interventional cardiologist, as you said, at Geneva University Hospitals, and I prepared 2 cases to present you today. So those are my disclosures. The first case I prepared for today is a 50-year-old gentleman who was an ex-smoker known for dyslipidemia, and he was admitted to our cath lab for acute coronary syndrome. On echo, he had normal LV function, and his only medication on admission was antiviral treatment for HIV infection. You can see here the right coronary artery with intermediate stenosis in the proximal segment, and on the right of the slide, you can see a severe stenosis on the first marginal. You can see here an intermediate stenosis on the LAD on the bifurcation with diagonal 1. And during that session, I performed PCI to the first marginal with 1 drug-eluting stent. And I performed invasive functional assessment of the LAD with means of IFR, which showed an IFR of 0.74 with a focal pattern on pullback. So I'll schedule the patient for an PCI to LAD in the next session that I performed 1 week later. So the strategy for his PCI was PCI to LAD and diagonal 1 with a Medina 111 bifurcation lesion. And I planned provisional stenting with 1 DES and 1 DEB to diagonal 1. You can see here on the left of the screen the lesion again. So the lesion is here, intermediate stenosis with positive IFR. It was a Medina 111 lesion. So I started with pre-deal of the LAD with a 3.0 balloon, as you can see on the right of the slide. And I performed the PCI to the proximal 2 mid LED with one drug-eluting stent, 3.0 times 35 millimeters. Can you play the intro, please? You can see here the results after PCI to the LED with one DES. I performed POT of the LED with two different balloons, the distal and proximal part of the stent. After that, I proceeded to pre-deal of diagonal 1 with a 2.0 balloon. And on the right side here, you can see how the delivery of the solution balloon was really smooth, even with a very long balloon, which was a 40 millimeter long balloon. And I just filmed here the delivery of the solution. You can see here very deliverable, even through the strut of the previously implanted stent. So I performed PCI to diagonal 1 with the solution 2.5 40. And after that, I did kissing balloon to LED and diagonal 1, as you can see here on the right of the screen. After that, I performed POT of the LED, and on the right, you can see the final angiographic results. Second case I prepared today is a very young patient, 40-year-old gentleman who is a current smoker. He has no relevant past medical history. He was admitted also for an STEMI to our cath lab, and he had a preserved LV function. You can see here his coronary angiogram. On the left of the slide, you can see his RCA. No epicardial lesions. And on the right hand of the slide, you can see his left system. Discrete atherosclerosis on the circumflex. The next slide, please. And you can see here the culprit lesion of the acute coronary syndrome, which was a lesion on the diagonal 1, which was quite a big branch with a bifurcation lesion.
Can you play it? Can you click on the image?
Yeah, I'm sorry. So this is the culprit lesion. There's quite a bit of overlap, but you can see it here in the background. Sorry, I don't have control over my slides, so I don't know if you can play them for me. Thank you. So the strategy for this PCI, considering a reference vessel diameter and anatomy, and considering as well that the compliance of the patient might not be optimal, I decided to perform PCI to diagonal 1 and its side branch with two sirolimus saluting balloons. Next, please. So I started with the predilation of diagonal 1 and its branch with two non-compliant balloons. After that, I performed kissing balloon to diagonal 1 and its branch with two solutions, 2.5 20. And on the right, you can appreciate the final angiographic results. Thank you. On this slide, you can see the results of a meta-analysis comparing DCB versus POBA for bifurcation side branch PCI. This meta-analysis included 3 RCTs. And as you can see here, DCB is not only safe, but shows improved side branch late lumen loss. So my conclusions for today are that there's a strong rationale for investigating use of DEB in different clinical settings and PCI scenarios. I think there's different coronary lesion subsets favoring DEB PCI and avoidance of metal stent implantation. Among those lesions are, of course, bifurcation lesions, especially the one requiring treatment in both limbs, Medina 110 lesions, as well as bifurcation ISR. ISR stenosis are already also another subset of lesions that are interesting to treat with DEB PCI, as well as diffuse high-grade coronary disease. And of course, we will await further RCTs to have more clinical evidence regarding the use of DEB for bifurcation PCI. Thank you for your attention.
Thank you so much, Sophie. This was great 2 cases. We have a couple of questions, of course, but also I'm going to be able to address some of the questions that comes from the audience. Very important to be very interactive. But just a quick question to you, Sophie, regarding when you have the same question I had with Simon. When you have provisional stenting, so you put a stent in the main branch, and then you want to treat with DCB the side branch. As I saw, your technique is to go ahead with DCB, use a solution at the side branch. There was a very long one, by the way, 40. But then you stay there with as an only balloon, not kissing, for like 1 minute. What is the recommendation for how long should you keep that inflated?
You mean so for the side branch PCI?
Yeah, in general for DCB. How about particularly for solution? Because I generally try to wait at least 1.5 minutes, 2 minutes.
Yes.
Generally. But what is the formal recommendation for solution?
The formal recommendation by the company is at least 1 minute, and I always try to go to 2 minutes if the patient tolerates it.
I agree. I do the same. So then you put a balloon, and then after you deflate, and you go again with kissing.
Yes.
With the same balloon, and then you put a balloon in the main branch and you perform kissing.
Yes.
Good. It's good because you inflate it twice. If there is any residual drug, it goes right. It's more effective, perhaps, if you inflate twice. So for kissing, you use the same DCB, which is already parked at the side branch. Good?
That's usually how I do it.
Yeah. Could you agree with that, Carlo? When you perform DCB at the side branch, what's your technique?
Yeah, Alexandre, this is an important point. In my case, I highlighted and like to discuss because there is no clear data showing, demonstrated it's better to perform drug-coated balloon dilatation in side branch before or after main vessel stenting. There is no really study addressing this point. So I look into the study we have published with the drug-coated balloon in side branch with brachitaxel drug-coated balloon. Actually, in the majority of the case, they perform drug-coated balloon before main vessel stenting. And then sometimes they do kissing according to what happened to the side branch. Because we know the recommendation is to perform kissing in case of main vessel stenting alone, only in case of suboptimal result in the side branch. So I personally like to do drug-coated balloon in the side branch before main vessel stenting. And then finally, I don't inflate again the balloon in the side branch unless the results after main vessel stenting is not good.
So good. I have one question from the audience here, addressed perhaps to Simon, which is about lesion preparation. Do you get intramural hematoma more commonly with angioscope, DASH, Scoreflex versus warfarin versus cutting balloon? Question to you, Simon.
Okay. So intramural hematoma normally would be released by using a cutting or scoring balloon rather than caused by using a cutting or scoring balloon. It's more blunt trauma that's going to give you an intramural hematoma. And there certainly are case reports of people releasing, for example, spontaneous coronary dissections with a cutting balloon. So I'm not sure I know the direct answer to that question. In our hands, we tend to use more of the Scoreflex and an NSA alpha than they do Wolverine. And the reason for that is I sort of keep the Wolverine as the last one of those types of balloons because I actually think they are more aggressive. I think those cutting blades are more aggressive than the polymer blades or the wires that you're using with Scoreflex and NSA alpha and that type of balloon. And certainly I've seen more vessels that I've had to stent my way out of after Wolverine as compared to Scoreflex. So I sort of keep it as the next line of specialty balloon after things like Scoreflex and NSA alpha. So I haven't really answered the question.
Yeah, as I understood, you are really a believer that you only stent when you really have to stent, right? So you try even to, in de novo lesions, large vessels, you try to leave it with DCB alone without stenting, right? That's your mostly, perhaps the most often strategy that you have in mind. Is that correct?
Yeah.
So by doing that in your practice, have you noticed any perhaps increase in the using of scoring balloon and rotablator and more aggressive pre-dilatation than usually when you used to stent everybody?
That's a great question. So I think lesion preparation now is becoming increasingly important with everything that we do. And I think that was driven partly by scaffolds. But I think now people are beginning to realize that with a drug-eluting stent, to get the best, really good long-term outcome, you need really good lesion preparation as well. And that's being driven by the very late events that you get with stents, and also the intravascular imaging that we now have at the time that can show exactly what lumps of calcium, for example, or undilated portions of the lesion that there are there. So in answer to your question, we do a lot of lesion preparation before we DCB, generally. Having said that, I don't think we're necessarily as aggressive as some people are, because a lot of the time you find that gentle inflations are enough. We certainly use a lot more cutting and scoring balloons than a lot of centres, I think. I do a bit of rotablation, not a huge amount, and I probably suffer from what I'd call rotor regret occasionally when I should have done it and I haven't. We use a lot of shockwave and then DCB. So yes, all our angioplasty is done, and then at the end, we deliver a DCB.
So one quick question to Carlo and Sophie. Is there any situation in side branch when you decide to dilate, when there is an indication for balloon or kissing at the end of the bifurcation treatment? Is there any situation that you would think about POBA? Because in my opinion, in the vast majority of the cases, if I need to touch the side branch without stenting, when I need to just optimize or have a residual stenosis or a compromised FFR, when I want to go with a balloon in the side branch, I always think about DCB. What about you? What about you?
So in my opinion, the situation in which I must go with the drug-eluting stent in side branch include dissection type 3, so flow limiting dissection after the dilatation, and residual stenosis more than 30%. But of course, if there is residual stenosis more than 30% after lesion preparation, even with scoring balloon or cutting, whatever, there is no indication to go with drug-coated balloon, because we know from the data that if the results of the preparation is not good, the outcome with drug-coated balloon is not good. So in this case, I go with drug-eluting stents.
What about you, Sophie? So when you decide to touch the side branch, what do you use versus DCB?
If I have to touch the side branch, based on worse late lumen loss with POBA compared to DCB, I would choose DCB or drug-eluting stent if I have to treat the side branch.
Great. So let's move to the last case so we can perhaps have a little bit more discussion towards the end. And again, it's Carlo Briguori. Carlo works in Naples in Italy, Mediterranean Cardio Center. Carlo, please share your cases.
So this is a case I treated 65 years old man with the common risk factor, quite obese, body mass index more than 33, with the inferior wall STEMI, coming in cath lab in less than 3 hours. Ejection fraction was preserved. Anyway, the angio showed a tight occlusion, the dominant circle, with a type 111 lesion including a large obtuse margin. As you can see, this the QCA analysis showing the bifurcation. The main vessel reference diameter was proximal 3.5, distally before occlusion is 2.3, and the side branch is obtuse marginal. As you can see, the reference diameter proximal at 2.4 and distally 1. The MLAD was 1.4. So the length of lesion in the side branch is quite long, is 36 millimeter. And as you can see here, and also the angle of bifurcation is 55 degrees. So this is what we found. So this is a complex bifurcation. So this is the definition criteria of complex bifurcation. So a side branch stenosis more than 90%, the length more than 10 millimeter, severe calcification, and bifurcation angle more than 75 degrees. So we have at least two criteria of complex bifurcation in the context of STEMI patients. So how to handle? One question, provisional approach or elective to stent approach? This is a question to all the panel.
I think I would start with a provisional approach and see the result after main vessel stenting and see if I need to move on to treatment of the side vessel, the side branch.
I think I know Simon's answer. Neither of those. You would go with DCB in both branches. Tell us, Simon.
Yeah, I'd wire both and gently balloon them both open and see what it looked like, I think.
Okay, this is the second question. In case of a provisional approach in the side branch, what do you utilize? Conventional balloon or drug-coated? In case the drug-coated, which one? Paclitaxel or sirolimus coated?
So if you have to stent the main vessel, I think the DCB approach is if you've decided up front you want to treat the side branch, you do it first. If you're then rescuing the side branch and think that it needs a DCB, you obviously have to do it afterwards. I agree with Sophie from the point of view of if you're ballooning it, then you should be DCBing it. Which balloon do you use? Well, there's all sorts of studies going on at the moment around paclitaxel balloons and sirolimus balloons. And I guess it's what data you feel is most appropriate, what studies you happen to be in at the time, and what balloons you have on the shelf. I'd suggest you pick one that you know has some good data and some good drug delivery behind it.
Yeah, I agree with Simon, and I think I would start predilation with a conventional balloon, and maybe in this case, owing to the complexity of the anatomy, I think I would choose a good deliverable drug-eluting balloon, and I think I would go with a sirolimus-coated balloon.
Yes, thank you for your comments. So what we did, according to these are the last recommendation European Society of Cardiology in the bifurcation lesion. The approach should be provisional, so stenting the main vessel and the balloon in the side branch, and if possible, it's preferable to have a drug-coated balloon in the side branch. So main vessel, drug-eluting stent in the main vessel and drug-coated balloon in the side branch. There are very few limited data on drug-coated balloon in both main vessel and side branch. Of course, we don't have in acute MI patients. This slide has been already presented by Sophie before, showing meta-analysis of drug-coated balloon, paclitaxel-coated balloon versus conventional balloon in the side branch. The lay lumen loss is better in the case of treatment with the paclitaxel-coated balloon versus POBA. This is another meta-analysis published the last year in Frontier Cardiovascular Medicine, showing the 6, 9, and 12 months follow-up, angio follow-up, the TLR, clinical follow-up, TLR in the side branch, which is quite similar, no significant difference between drug-coated balloon, paclitaxel, and conventional. Now we have this new generation sirolimus-eluting stent has been presented before, containing 1 milligram millimeter squared of sirolimus with a new optimal release with micro reservoirs, allowing optimal release, including the micro reservoir include the biodegradable polymer plus sirolimus, and this allow a quite optimal release of elution of the sirolimus into the wall. This study showed the performance of solution in the blue as compared to everolimus eluting stent elution in green, in blue, and in orange we have another sirolimus eluting balloon with crystalline formulation. As you can see, 9 days after implantation, the mean sirolimus concentration in the vessel wall is quite similar between everolimus eluting stent and sirolimus eluting balloon solution. On the contrary, is much less with the alternative crystalline sirolimus DB. And most importantly, the percentage of the drug transferred into the wall at 1 hour, it's almost 40% with the solution as compared to less than 10%, 5% with the paclitaxel eluting balloon like Lutonix and Impact. So what we did, provisional approach with DS in main vessel and solution in the side branch. Of course, it's really important, as we stressed before, it's really important to have optimal angiographic result or acceptable angiographic result before drug-coated balloon dilatation. This includes optimal predilatation with the scoring balloon, cutting balloon with the 1.1 balloon vessel ratio. We need to have at least less than 30% residual stenosis or FFR more than 0.80. Otherwise, it is not recommended to go with drug-coated balloon, but it's recommended to go with drug-eluting stents. And so these are another study, even though it's done in stent-wise stenosis, but the concept to me is important. Before having, in order to have optimal result with the drug-coated balloon, we need to have a residual stenosis after lesion preparation less than 20%. The drug-coated balloon to vessel ratio should be almost 1, not less. And the inflation time, the drug-coated balloon should be at least 16 seconds, 1 minute, not less. This to me are very important to have a better and optimal long-term outcome after drug-coated balloon dilatation. So we predilate the side branch with the Scoreflex scoring balloon 2.5 millimeters, so 1.1 balloon to vessel ratio at 18 atmosphere. We had quite good angio results. So after that, we go in the side branch with the solution 2.5, 14 millimeter length. We inflate 12 atmosphere for 16 seconds, 1 minute. The balloon to vessel ratio was 1.1. And after that, we implanted the main vessel, the DS in the main vessel, trio 38 millimeter pot, and without kissing, we did the final results, which was good. So I'm sorry the movie doesn't go. So the final result is the QCA analysis. The final stenosis, diameter stenosis, the main vessel was less than 10%, and most importantly in the side branch, as you can see here, the minimal lumen diameter was 1.67, and the final stenosis was 10%. And the results was good. We did the angio follow-up. This patient is 6 months. I'm sorry the movie doesn't go, but the QCA analysis is, which is to me very important, show a minimal lumen diameter of the side branch 1.45. So the late loss at 6 months was 0.22. So to me, this is a good demonstration of the approach with in a complex bifurcation, with the long lesion in the side branch, with the drug sirolimus eluting balloon solution, which is a very complex bifurcation issue. Thank you.
Thank you, Carlo. This was great, also embedded with some literature data, which helps us to make our decision. And thank you for introducing the new technology. I think that we're all very excited with the opportunity of having sirolimus-eluting balloons in our shelves. And I think that it was a challenge in the past. As you know, paclitaxel is much easier drug and more hydrophilic. And now with technologies such as with Meta-Alliance and solution, this is certainly feasible. So it's great to hear the mechanism of action and your mechanistical slides. I have a question to the three of you. I think we talked a lot about how to really try to avoid stenting and leaving with a good balloon result, right? We all wanted to have this. That's why we invested a lot of our time in studies with bioabsorbable scaffolds, which unfortunately had disappointing results. But again, having DCB with several options, paclitaxel, sirolimus, and more advanced balloon technologies, I think we are more open to leave the vessels uncaged, right? So I think that's something that at least our generation believes. I don't know, the younger generation might be a little bit more resistant. I'm sorry, Sophie, you're a young generation too. But anyways, my question to you, in your practice, what is the acceptable percentage of patients that we will cross over to stents? There is an ideal situation that probably perhaps less than 20%. You end up, stay with a good balloon result in 80% of the cases. This would be, for me, a very ideal situation. But in your point of view, what would be your ideal number? And in your practice, in reality, in real life, what is the percentage of cases that you have to cross over to stenting because you don't like the result for several reasons? Simon.
Okay, so our data would suggest that as a department, certainly for a few years, we were DCBing and stenting at equivalent rates, as in 50-50. We obviously have quite a spectrum within our department, from me at one end to some people that love doing lots of complicated bifurcational stents at the other end. For the last few years, my crossover to stenting rate is something less than 5%.
Very aggressive. Fantastic.
It's very gentle, not aggressive.
Very gentle, but aggressive numbers. I like that.
Okay.
Sophie.
I think our numbers are unfortunately not as impressive as Simon's numbers. I think in our practice, we try since maybe 1 year to stent less and less. I think we've increased a lot the use of DEBs after a phase where we put a lot of scaffolds. And I think now those are patients in whom we try to treat with DEBs instead. But I think we're still at a 80-20% ratio. And I guess aiming to lower the amount of deaths that are implanted, but we're as far as not as at the same stage as Simon.
Mm-hmm. Carlo.
So Alexandre, yesterday I spoke with Antonio Colombo, who is our master. He did some days ago a distal left main, was a trifurcation. He told me they implanted only one stent. He was surprised because in the past, as you told, for sure he will implant at least two stents in the left main LED, circ, and the balloon in the intermediate, or 3 stents. But he was surprised by the results with only one stent and drug-coated balloons, sirolimus-eluting in intermediate and ostium in the circ. So it's really important to learn this approach to, and also I personally now in bifurcation, also complex bifurcation, in 80% of the case, I don't plant a stent in the side branch. Of course, there are a percentage, 15, 20% of cases in which we need to have 2 stents, but in the majority, we can finish the procedure without a stent in the side branch. And the long-term outcome seems to be good.
Great. So this is, I think, an important message, because in the vast majority, we still thinking about stent. The vast majority of services around the world will think about stenting, but when they think about DCB, it's good to have this kind of sense that, you know, only a minority will have to cross over due to suboptimal result. So talking about suboptimal result, it's about lesion preparation. I think we are all convinced that we have to take a little bit more time and dedication to have an optimal result before you massage with a DS. Well, I'm sorry, with a DCB. So Simon, one question to you. Since you were between the 4 of us, I think you are the most perhaps aggressive in a nice way to lead with DCB. So one of the main reason why we want to use DCB is because we want to leave nothing behind and give back the physiology to the vessel and not have to cage the vessel with a lot of metal. So we all understand that. But there is another issue, which is cost. And the hospitals, the administrations, now they are very sensitive to cost. And one of the reasons is perhaps, you know, instead of placing 3-4 stents, you can get away with a couple of DCB. But on the other hand, you're going to use more resources to pre-dilate these lesions. So you talked about shock wave, you talked about rotablator, cutting balloons. So all this devices that we have to use for lesion preparation is going to increase the cost. Is this a concern to you or to your hospital? And have you done any kind of analysis to understand that using more preparation and imaging, we will spend more money than the plain old DS?
That's another fantastic question. So there are a number of bits to the answer to that. The first one would be, I think now lesion preparation should be optimal no matter what you're doing at the end of your procedure, whether it's a DCB, a drug-eluting stent, or a scaffold. And I think we're now beginning to realise that that's the case. So all of these different lesion preparation tools should be used in every angioplasty. And actually, perhaps the way we should be going is doing the lesion preparation, and at the end of all of that, having all the options available to us and then picking the correct one and for the correct anatomical lesion in the patient that we have in front of us. So I suspect we'll end up with all of these possibilities of balloon stents and scaffolds available to us. And as long as we've done good enough lesion preparation, they should all be on the table available to use at the end. What was the rest of the question? I've forgotten.
No, it's essentially the cost. Any cost analysis? Okay,
yes. So, interestingly, a few years ago, before people started worrying about this, we internally, well, when I say we did, somebody did for us, without telling us, a cost analysis by operator in our department, which obviously was a rather brave thing to do because none of us knew that this was coming. And out of the 8 operators, the 2 cheapest operators by way of amount of kit used were the 2 highest volume DCB operators. I can't really explain that to you other than to say that we probably do a lot less imaging. And I think we all use a lot of lesion preparation balloons, whether we're stenting or not.
Good news. I think that in the future, with so many big studies going on, I think that we're going to be able perhaps to answer more properly to these questions in a sense that we're going to have randomized clinical data to analyze. So we are getting close to the end. There is one question from the audience that I can answer. Is also talking about lesion preparation. When you have a dissection that you're not sure what to do, what should you use, IVUS or OCT? I can answer. I think IVUS is the right imaging modality to use, because if you use OCT, you have to give a strong injection of dye, of contrast, and you might increase the dissection. So my last question to the three of you, so we can finish, is that even without very strong data, definitive data, what's your reaction inside your heart now? And I'm going to ask about your feelings, not a definitive answer. If you have both, without data yet, paclitaxel-eluting balloon and sirolimus-eluting balloon, what's your reaction? Again, very philosophical, because we don't have the right answer. Would you feel perhaps safer or more efficacious in the future? Any reaction without, again, I'm going to defend you, no data, but what's your gut feeling? Sirolimus or paclitaxel? Sophie?
Intuitively, I would answer sirolimus. But yeah, as you said, without data to back this up, but this would be my feeling.
Carlo?
So, Alexandre, I did an analysis in my hospital in stent stenosis only. I review all the case we did with the paclitaxel and sirolimus, different generation, and we found no difference. So the feeling is sirolimus should be superior, but at the moment the data we have doesn't show, at least in stent stenosis, didn't show any difference.
Simon?
Okay, this is not going to be a short answer. So the reason why people were put off paclitaxel was because of first-generation drug-eluting stents with paclitaxel on them, wasn't it? And I think after the dust had settled, the answer was paclitaxel stents probably had a more late lumen loss and therefore more restenosis. And that was the majority of the reason why all cardiologists moved towards limus drug-eluting stents. We've all used limus drug-eluting stents for years. We like them, they work, they're safe. So if you ask any cardiologist what drug they want, they would always want a limus rather than paclitaxel. And on a stent, that seems very reasonable. On a balloon, that's much more open to question, which is why there are so many fantastic studies going on currently, including the Solution de Novo study I'm fortunate enough to be involved with. What do I think long term? So there's two aspects to it, aren't there? There's the safety aspect, and separately then there's the efficacy aspect. Safety-wise, early, it's not actually to do with what sort of drug you have on your balloon. It's whether you do good angioplasty and know what not to leave. As long as you haven't got some ridiculous balloon with something on it that is actually toxic, and that's never going to be the case because we're never going to get to that stage. Longer term, then, what you're looking at is your restenosis rate at 5 to 10 years. Can't answer that one yet. You would hope that both drugs would work. The only caveat I have against sirolimus currently is lack of evidence of late lumen gain, which we rely on quite heavily with our paclitaxel balloons.
Fantastic answers. I think that perhaps in the future for a diabetic patient, we're going to use both paclitaxel and sirolimus, right? Who knows?
Wow, there's a study.
Good news is that this field is moving forward very quickly. I think that very soon we're going to have answers to some of these questions. And also the penetration of DCB is getting higher as people feel more comfortable with not only the results, but also having a little bit more tolerance not to go ahead and stent all the lesions. I think that we're going to learn a lot in the near future. I thank you so much. The three of you were fantastic with lectures and cases. I thank Med Alliance, InCath Lab for this opportunity, and all the audience that was very interactive asking questions. Thank you so much.